Okay, good morning, everybody. Let's get started. First to speak is Associate Professor Samuel Hahn. Please come to the podium. You're going to talk about workup for etiology of the patient with chronic pancreatitis. And we have heard so much about you, Samuel. Uh, Only nice words, but we know that you now work at Ohio State University. Well, most welcome.
Thank you, Dr. Arnella. Really appreciate it. I really want to thank everyone for attending today, and I really want to thank the course organizers, Dr. Sachin Wani, Dr. Rob Shah, Dr. Anna Deloy, for inviting me to come back and talk about a topic that actually never gets discussed at a conference, especially at an advanced endoscopy conference. So we're going to talk about working up the etiology of the patient with chronic pancreatitis. And if you take home anything today, I want you guys to remember that alcohol is not the only cause of chronic pancreatitis, because we commonly think that, but I have no conflicts of interest to report. So the objectives of today's talk are to provide an overview of the different etiologies of chronic pancreatitis, while also providing some practical guidance on how to work up patients with chronic pancreatitis. Before we really get into the thick of it, I think it's really important to establish a definition of chronic pancreatitis. So while previous definitions of chronic pancreatitis have largely focused on morphology of the pancreas, the field has been moving more towards a mechanistic definition. And so there was an international consensus group led by Dr. David Wickham from Pittsburgh, who basically defined chronic pancreatitis as the pathologic fibroinflammatory syndrome of the pancreas in individuals with genetic, environmental, and other risk factors who develop persistent pathologic responses to parenchymal injury or stress. And I think this is a great definition in that not only does it take into account risk factors and disease progression and outcomes, but it really provides clarity in terms of distinguishing chronic pancreatitis from other disorders while recognizing that there is significant disease heterogeneity within chronic pancreatitis in terms of susceptibility, onset, modifying factors, disease progression, and outcomes. And it really creates an avenue for personalized medicine. So we're going to start off with the different kind of classifications that really help us as physicians to be able to find the etiology of chronic pancreatitis. So I'm going to start off with the Tiger O, which is actually my personal favorite to use, and I use it in all my clinic notes. But basically, this was actually formed for the North American Pancreatitis Study 2 group, really to kind of document what are potential risk factors or modifying factors for chronic pancreatitis. So T is for toxic metabolic, I is for idiopathic, G for genetic, A for autoimmune, and then R for recurrent severe acute pancreatitis, and O for obstructive. But it's really actually based on the sentinel acute pancreatitis event model, or the SAPE model. As you all know, basically, this model states that if you have an acute episode of pancreatitis and you have kind of other risk factors or other susceptibilities, then you can eventually develop kind of this pathologic inflammation and progression of pancreatitis. And then next, I want to talk about the Mannheim, which is actually very similar, but it basically operates on the assumption that in the vast majority of cases of chronic pancreatitis, patients will have multiple risk factors at play. And this one also kind of includes disease severity, but I want to basically lump these two together, and we're going to basically talk about the different etiology categories based on these two. So as with anything in terms of working a patient up for etiology, the three main components are getting a comprehensive medical history, select laboratory tests, and obtaining cross-sectional imaging. So we're going to talk about the toxic metabolic causes first. So alcohol is certainly the most common risk factor. We always say that heavy alcohol use is a risk factor, and it's kind of hard to define what exactly is heavy alcohol use. But in the literature, it's typically defined as having 80 grams a day of ethanol for about 6 years. And 80 grams a day, for your reference, is about 6 to 7 drinks of alcohol a day. And I really want to emphasize smoking. So smoking is an under-recognized risk factor. It's independently associated with the development of chronic pancreatitis. It also accelerates disease progression. And even secondhand smoking has been found to be kind of a primary cause, and especially in children. So something definitely to always ask about. And then in terms of hypercalcemia, we always talk about hypercalcemia as a potential cause of pancreatitis, but I really want to make note that 90% of cases of hypercalcemia are from hyperparathyroidism, so primary hyperparathyroidism, or hypercalcemia of malignancy, with only a minority of cases coming from conditions such as sarcoidosis or chronic kidney disease. And it's important to note as well that the vast majority of patients with hypercalcemia also do not develop pancreatitis. So, for example, in hyperparathyroidism, less than 7% of patients will have an episode of acute pancreatitis. And then in regards to hypertriglyceridemia, there's still a lot of debate about what level of triglycerides you need to have an increased risk of pancreatitis. But we do know that starting at a level of 177 milligrams per deciliter, you have an increased risk. And that risk really goes up exponentially. So once you have a level above 400, your risk actually increases ninefold. Something to note as well. And then in terms of medications, there are so many medications that have been associated with acute pancreatitis, but I just want to highlight the more common ones. So azathioprine, ACE inhibitors. So back in the day, phenacetin was an analgesic that was available. It was actually withdrawn from the market in 1983 due to its nephrotoxicity, but it was also associated with pancreatitis. And then in terms of toxins, a board question is always scorpion bites. I've never seen a case of scorpion venom-induced pancreatitis, but that is one that we always talk about. And the majority of toxins are actually chronic kidney disease related, and this is thought to be related to the kidney's inability to clear pancreatic toxins and also cause electrolyte imbalances such as hypercalcemia, which can cause chronic pancreatitis. And then DBTC is dibutylene dichloride, which is a common kind of household chemical. And this is what we actually use in mouse models to induce chronic pancreatitis. So 15 to 25% of patients with chronic pancreatitis, we will never find the cause of pancreatitis in them, so we label them as idiopathic. We typically categorize them as early onset or late onset, with the age of 35 as the cutoff. And I really want to make a note that a lot of these patients have complex genetic risk profiles, which we believe are contributing to their chronic pancreatitis. And then as a pancreatologist, the most common question that you're going to get from a referring provider is, when should I order genetic testing? And to really simplify this, I want to basically say that genetic causes should be suspected in patients with early onset pancreatitis, so those having it before the age of 35, with no other obvious causes, or when there is a positive family history of pancreatitis, diabetes, dyslipidemia, and pancreatic cancer. And to simplify this even more, in terms of the common autosomal dominant mutations, the most common one is PRSS1, which is the trypsinogen gain of function mutation, and then the MODY8 variation in the carboxyl ester lipase gene. And then in terms of autosomal recessive mutations, we always think of classic cystic fibrosis, which, as you remember, is when you have two disease-causing CFTR variants on different alleles. There also is CFTR-related disorders, which is when you have one kind of pathogenic CFTR variant, and then you also have kind of reduced CFTR function. And so this can be actually monosymptomatic, where you only have one organ involved, such as in the pancreas, but it can also involve multiple organs. And this kind of typically presents as when you have male infertility, chronic sinusitis as well. And then, of course, we always have to talk about the SPINK1 mutation, which is actually present in 2% of the population. And then tropical pancreatitis is really its kind of own form of pancreatitis, which we actually still don't really know a lot about. It's very kind of heterogeneous, a lot more than we previously thought, but it really represents a complex genetic disorder. And the two typical kind of phenotypes that we see are tropical calcific pancreatitis and fibrocalculous pancreatic diabetes. And then autoimmune pancreatitis is really a distinct form of pancreatitis that's characterized by frequent presentation with obstructive jaundice, with or without a pancreatic mass. So in those patients who have an acute presentation of autoimmune pancreatitis, they'll typically present with jaundice and or mass with pancreatic swelling, and the swelling can be either diffuse or local. For those who have a late presentation of autoimmune pancreatitis, this is really kind of hard to distinguish, but they'll already present with atrophy, calcifications, and ductal dilatation. And kind of like their trademark symptom is that they don't have any pain, and they've never had any recurrent episodes of pancreatitis. And I really want to make the point that imaging and steroid response alone cannot distinguish between the two types of autoimmune pancreatitis. So serologic abnormalities such as an elevated IgG4 level are typically only seen in type 1 autoimmune pancreatitis. We currently do not have any serologic markers for type 2 autoimmune pancreatitis. And while inflammatory bowel disease is associated with both forms of pancreatitis. It's more common with type 2 autoimmune pancreatitis. So this was kind of an international consensus document outlining how to diagnose and manage autoimmune pancreatitis. And it starts with imaging, trying to look for findings of the pancreas. Typically, we say like a sausage-shaped pancreas. And also looking at other organs as well that can be commonly involved, measuring serum IgG4 levels. And then if that's not enough to make the diagnosis, sometimes we consider doing ampullary biopsies. And a common question I receive is, when do you perform a EUS-guided biopsy of the pancreas? Obviously, no one really does a percutaneous biopsy anymore, but when are you going to do an EUS-guided biopsy? And I would say in general, obviously our medical pancreatologists really help guide us in this when there's a high level of suspicion. But, a lot of these times with a high level of suspicion, we're just going to empirically treat with steroids, and you don't necessarily need a histologic kind of confirmation of autoimmune pancreatitis. But there are these patients where we are kind of equivocal, and they usually will present with a pancreatic mass. And because you want to exclude pancreatic cancer, this is a good kind of subset of patients where you can perform a biopsy and see if there are any histologic features of AIP type 1 or 2. And then I do want to note recurrent acute and severe acute pancreatitis are also risk factors by themselves for the development of chronic pancreatitis. And then in terms of these are kind of outside of the typical ductal or acinar cells. So trauma to the pancreas, ischemia to the pancreas, as well as post-ERCP pancreatitis and infections that we commonly talk about as well. In terms of obstructive etiologies, kind of like the final category, this is something where actually as advanced endoscopists, we can play a role in diagnosing and treating. So ampullary stenosis is a common etiology, pancreativism, localized lesions such as a main duct IPMN, and then very rarely anatomical variants such as where you have choledochal cysts, anomalous pancreaticobiliary unions, and annular pancreas. And this is a patient with a main duct IPMN with pancreatic duct stones. And this is a series that actually Raj and I published in coordination with Isaac Reichman's group. But you can see here, you can see the mouse, this patient has really massive pancreatic duct stones, and then they have this really dilated pancreatic duct. And so just by looking at the imaging, you would think they have, terrible chronic calcific pancreatitis. But when you do pancreatoscopy, you'll actually find that they have signs of main duct IPMNs. And so this is a patient I did an EUS on with a dilated PD of 21 millimeters. But they also had mucin balls all throughout the pancreatic duct. So this is a case where it's actually the main duct IPMN that's driving it. Actually, this is an old version of the presentation. I don't know if we have the new version that has all the videos. I was hoping to show some videos as well. If we can get access to that.